We want to officially welcome you to today's virtual Lupus Mini Health Conference. After last year, we all realized how important it is to be able to gather together, whether in person or virtually. We at the LFNC are proud of the fact that we continue to support lupus patients through our support groups and our office hours with Dr. Parsa virtually throughout the pandemic. Who would have thought that more than a year after the shutdown, we would still be hosting virtual events? But to be safe and to be able to extend our audience further than the San Francisco Bay Area, we are very excited to offer a series of virtual lupus mini health conferences over the next 4 months. We hope that during this conference you will learn something new and remember that you are not alone on your lupus journey and that we at the LFNC are here to support you.
Welcome to the first virtual lupus mini health conference presented by the Lupus Foundation of Northern California. My name is Karine Belazna, and I'm excited to be your host today. I began volunteering with the LFNC in 2012. Over the past 10 years, I have created their online medical article library consisting of over 200 document resources, assisted in preparation of annual financial audits and tax returns, and provided a variety of other financial and business advisory services. I am an instructor for new patient education classes and have helped plan and facilitate events such as the Outrun Lupus 5K, the Purple Ribbon Awards Gala, and LFNC hosted medical and health conferences. We are happy you could join us today. Hopefully you'll be here tomorrow too. The Lupus Foundation of Northern California has 2 more upcoming lupus mini health conferences planned for 2021 on August 27th and 28th, and a Spanish language conference on October 15th and 16th. Don't miss your chance to help LFNC outrun lupus on September 25th. The 5K will be a hybrid event, so join us at Campbell Park in person or from wherever you feel comfortable. For additional information or resources, please visit our website at www.lfnc.org or email us at communications@lfnc.org. Before we begin, I want to make sure you are all aware that this is a 2-day event. You do not need to sign up again for tomorrow's sessions. You can use the same link you used for today. Last housekeeping item. We want to hear your thoughts on this conference, so be sure to complete the survey when the webinar ends. This is the only way we can hear what you liked and any suggestions of what you would like to see in the future. So now I will go over the agenda quickly and then we'll get started. The first hour, Dr. Bush will discuss lupus diagnosis and treatments, followed by 15 minutes of live Q&A. You can ask a question by clicking on the Q&A button at the bottom of your Zoom window and typing your question, either during the presentation or during the Q&A session. You can ask questions anonymously by clicking the checkbox next to your question before clicking submit as well, so don't be shy. We will then reconvene at 2 p.m. for our wellness session, which will be led by lupus warrior, Alameda support group leader, and makeup artist, Jane Tipiachin. Jane will do a demonstration on how to artfully apply your makeup and how to cover up lupus-related scars and darker pigmentation. This makeup demonstration will last until 2:40. When it's finished, please be sure to complete our survey. I am pleased to begin our first keynote session. Looks like we have about 15 people logged in and watching right now. Let me introduce you to Dr. Bush. Dr. Bush recently retired from clinical practice after serving for many years as the chief of the Division of Rheumatology at Santa Clara Valley Medical Center. He served on the Lupus Foundation of Northern California Education Committee from 2000 to 2008, has peer-reviewed medical journals that dealt with lupus, and is the author of numerous studies and publications on lupus. Today, he will be speaking about lupus diagnosis and treatments. Welcome, Dr. Bush.
Yep. Thank you. Is my video working okay? All right, well, thank you very much. I'm going to be talking about lupus diagnosis and treatment today. I've given a similar talk to this in the past, but I've done it live. This is the first time I've done it virtual. So for the talk today, I'm going to initially present two sample cases, one of a new lupus patient and one of a returning lupus patient coming into clinic. And then I'll discuss how the immune system works and how it might affect people with lupus. I'll review some of the common symptoms and signs of lupus and then discuss treatments. I'll review the two cases. In the end, we'll review them in light of all the information that we've covered. So I'll start with case number one. This is a new lupus patient who presents with a rash and some anemia. A 23-year-old woman. She noticed a red rash on her face over the last few months. And the red rash on the face last few months, and her fingers have been turning blue and red in the cold. Due to the increasing fatigue, she went to an urgent care center and had a blood test done. Is it sharing my screen? No, okay, none of that came up, it disappeared.
Okay, we're sharing now.
There we go. Oh, sorry, I wasn't sharing my screen, but now I've got it on. So the first is a new lupus patient presents with a rash. She developed the rash last month or two, and it's been worsening. Also, her fingers have been turning white and blue when it's cold out. Because of some increasing fatigue, she went to the urgent care clinic, and they noticed that she had a new anemia, which is a low red blood cell count. The urgent care doctor noticed this combination of signs and thought maybe it could be due to lupus and sent off a lupus screening test, which came back positive. So she's been referred to the arthritis clinic. And for the purpose of this talk, we're going to discuss what do we do for her the first time she comes to clinic. And we'll get back to that at the end of the talk. Now, case number two is a woman who has had lupus for 10 years. She's 38 years old. In the past, she had arthritis and pleuritis. Pleuritis is chest pain with breathing. These symptoms have been well controlled with some typical medicines we use for lupus, Plaquenil and low-dose Prednisone. She comes in for a recheck visit. She feels fine, but she's been noticing a little bit more rash on her face and arms. And at the routine visit, we do some labs, and the labs show that in the urine, there's some more protein, and there's a slight increase in the creatinine in her blood test. And I'll discuss these in a little bit regarding how do we evaluate and track renal disease in lupus patients. So we'll discuss at the end of the talk, we'll review what are we going to do with this patient as far as working up further and treating her. So let's get started talking about lupus. Why do people get lupus? Well, we don't know the exact reason that an individual will get lupus, but we have learned a lot about lupus over the last 50 years. One thing that's fairly obvious is that lupus is mainly in women. So there's something about female hormones that triggers lupus. About 90% of lupus patients are female, and most of them are in a childbearing age, so they have active hormones on board. Now, there are 10% of patients are men, so this is not exclusively a female disease or one related to female hormones. And I worked at Santa Clara Valley Medical Center over the last 30 years. I retired about 2 years ago. And while we were at Valley Medical Center, we had about 300 patients with lupus, and about 30 of them were male. So we did have that 10% of male. And they can get lupus that's quite severe, similar to what females can get. Now, there's another issue, which is genes, and it's been clear, if we go to the second point here about race, it's been clear for many years that there's a much higher rate of lupus occurring in Black Americans, more so than Asians or Hispanics, and both those groups more so than in Caucasians. So there's something genetic occurring regarding the onset and severity of lupus. In addition, there's an issue with identical twins. If one identical twin gets lupus, does the other twin get it? Now, lupus is seen in the general population about 1 in 1,000. So if there was no genetic component to it, then if one identical twin got lupus, the other one would get it maybe 1 in 1,000 times. If lupus was 100% genetic and required just the right genes in order to occur, then if one identical twin got it, 100% of the other twins would get it. In observing what really happens, it's about a 30% risk. So if one identical twin gets lupus, the other twin who has exactly the same genes goes through life, and about a third of the time she'll get lupus and 2/3 of the time she won't. So there clearly is a strong genetic component, and there's also some sort of trigger that has to occur. Now, in the last 10 years, there's been a real revolution in science and the ability to look at the human genome, to look at all the genes at once in our chromosomes. And in doing so, they've found that there's about 100 different immune-related genes that are linked to lupus. And probably what's happening is all of us have a few of these genes because there's so many of them, but it's only when you get a certain number of them, 20 or 30 of them, or get certain of them that are a little more potent, that you're at big risk of getting lupus. This hasn't been completely worked out yet. Of interest, just in the last year or two, is that they found a key gene on the X chromosome, and the gene's called the toll receptor 7. And what's interesting about this is this gene for lupus that helps to trigger lupus is on the X chromosome, and women have XX chromosomes. They have 2 copies of X, whereas men have X and a Y. So it may also feed back to why women are more likely to get lupus, is they have the possibility of this deleterious gene happening on 2 X chromosomes that they have versus just 1 for men. And then finally, we'll get to environmental triggers. There's been a lot of work done trying to find out why at a certain moment in time a person who is susceptible to getting lupus suddenly develops all the symptoms of lupus. And there has been no easy answer to this, but there's a lot of evidence pointing towards a risk that is increased if someone smokes or is exposed to secondhand smoke. There's also been some evidence about viral infections triggering lupus, particularly the Epstein-Barr virus, but still in most cases lupus, we don't see any clear preceding infection. There's been some work done on toxins such as mercury in the environment that make lupus a little bit more likely, and there's some evidence that when people are under a lot of stress, they're more likely to develop an onset of lupus. So we'll have a couple slides here talking about, what causes lupus, what cells in the body are involved in the onset of lupus. And it all comes down to the immune system. Your immune system are your white cells and your antibodies. We all need an immune system to stay alive because the immune system fights off viruses and bacteria. So our white cells and our antibodies can recognize a virus or a bacteria and begin attacking it to spare us the infection. What's very amazing about the immune system is that some of the cells in the immune system have a function with memory. They will, when you get a measles or mumps infection or a vaccination as a child, these cells will recognize that measles or mumps and remember it and stay in your body, in your circulation the rest of your life, every day looking for a new measles or mumps infection. So as you accumulate a number of infections over your lifetime, you develop a wide array of white blood cells that remember those particular infections. So your immune system has the ability to cause a lot of inflammation and destruction of viruses and bacteria, and can also remember those infections for a number of years. Now, a third aspect of the immune system, which is really critical, is your immune system has to learn to not attack your own tissues. So you don't want your white cells going around in your lung tissue and thinking there's something wrong with your lung tissue and attacking it. So immune cells, they will learn which tissues are yours and which are foreign very early on in our lives. If there's a breakdown in this recognition of what is self, what is me, and what is a foreign body, such as a virus or bacteria, we'll call it autoimmunity. So what happens to the immune system in lupus patients? Well, the immune system makes a mistake, it makes an error. And your white cells begin to think there's something wrong with your own tissues and starts attacking your skin, joints, kidneys, and so forth. Unfortunately, as we just discussed, the immune system has a good memory. So when your white cells decide there's something wrong with your kidneys and starts attacking them, it remembers that error for many years, and this can lead to chronic destruction of tissues. Now, in treating lupus, we have medications that calm down the immune system, but we don't have any that can eliminate this error. So at this point in time, we have a lot of strong medicines which are very effective, but this still ends up being a long-term treatment scheme. So I just wanted to show you what white cells look like. What do the cells look like in your blood? So this slide here is a microscope slide. And this is, if you take a little finger prick and get a drop of blood and put it on a microscope slide, this is what you see. And most of these cells, these sort of lighter colored cells, are red blood cells, and they carry oxygen from your lungs to your tissues. There's some little tiny cells here, which I'll mention a little bit later, called platelets. And these little fragments of cells help your blood to clot if you have to avoid bleeding. And the rest of these cells are white cells. And one thing you'll notice right away is that the white cells come in a variety of shapes and sizes, and each of these white cells has different function. So where are these white cells, where do they live in the body? Where are our immune cells? Well, in babies, we have a lot of our white cells that are being processed in a gland called the thymus, and the thymus is inside the chest near the heart. And it's an organ that is very active in young children as they're processing a lot of different infections and immune responses that are being developed. In adults, it isn't quite so active. In adults, we tend to make our white cells in our bone marrow, the long bones of our legs and arms. And the white cells then will start circulating, and they circulate in the blood, and they also circulate in the lymph glands. And here it shows some lymph glands in the groin and the armpits and the neck. And the lymph nodes are where the lymph cells help to process any potential infections they're seeing. Now, we also have floating in our blood antibodies, and that's shown in this caricature down here. Some of the white cells are specialized to make antibodies. The antibodies are much smaller than the cells. You couldn't see them on that prior slide that I showed, but they float around as well, looking for specific types of infections to help with our attack on viruses and bacteria. And finally, in talking about immune cells, I just wanted to go into a little bit more detail on what kind of cells they were. When I showed that slide just a moment ago, you could see the white cells had a lot of different shapes and sizes. And this cartoon here shows all the different types of white cells, and I'm not going to cover them all because it's fairly complicated. But I just wanted to point out that that we have about 10, 15 different types of white cells. The ones in the bigger circle are called the rapid response cells. And these are cells in the body, they're sort of like attack dogs, and they don't really care what kind of infection they see, but as soon as they see something that looks like a bacteria or virus, they'll jump on it right away to try and get it out of our systems. So they work very quickly, and this is our first line of response, if we have a bacterial or viral infection. The smaller circle shows these B cells and T cells, and these are the cells that take a while to decide what an infection might be and whether it should be attacked when a virus or bacteria is in our system. And these are the memory cells. These are the cells that once they decide that they don't like the looks of a bacteria or virus, they will develop a long-term immunity to those cells and will patrol your body for the rest of your life, making sure you don't have that infection. And the B cells will make the antibodies. Now, this is a bit of a slow response. It takes a couple of weeks. And this is why, for example, with the COVID vaccines, a lot of them have a gap of 1 month between the first vaccine and the second vaccine. The reason for this is you get the first vaccine, and then they like to give these B cells and T cells 3 or 4 weeks to start developing a response before we give the second vaccine as a booster. Now, in treatment of lupus, we have some medicines like prednisone, and prednisone basically acts on all of these cells to slow them down slightly to help decrease the reactivity of the immune system. We have other medicines which are very specific, and some of them just affect the B cells or the T cells. So at this point, I'd like to move on to discuss the basic issues that patients have that have lupus. What are the signs of lupus? What are the organ systems that are involved in lupus? And you can see there's a variety of things: skin rashes, arthritis, lung and heart problems, kidney problems, blood problems, neurologic, blood clotting. And I don't want to overwhelm you with these. What ends up happening is in most lupus patients, they have maybe one or two of these organ systems involved. Nobody has all of them involved. So some patients will predominantly have a rash and a kidney problem. Another patient will have mainly a blood problem that comes and goes and will maybe never develop a kidney problem. So I don't want to overwhelm you as I discuss these, but I would like to be comprehensive and show you all the different manifestations of lupus. So first we'll talk about skin, and there's three basic types of skin involvement in lupus. The first is acute, and by acute we mean that it comes on suddenly. This is the kind of rash that can come on the face and chest just over a few days, and it may then disappear over a few weeks, or with treatment even within a few days will disappear. So it's acute, it's very sudden in its onset. These tend to be in sun-exposed areas, and if you can see my little cursor here, this is the typical rash we call a butterfly rash in lupus, and I guess someone imagines that when you look at the rash over the cheeks, it sort of looks like butterfly wings. It's also called a malar rash because this is considered the malar part of the cheek, so we call it a malar rash. This is a sun-induced rash. So if you notice the areas that are shaded, like under the nose, under the lips, there's not much rash, but areas that the sun would hit, if you imagine a light over your head, these are the areas that are impacted. And when you look at the chest of the patient below, you can clearly see that where she has a halter top or some clothing protecting the skin, there is no rash, and the rash is mainly over sun-exposed areas. So that's one real key in lupus is the sun is one of the big triggers for activating lupus, because the ultraviolet light in the sunlight cause damage to the skin. That causes some cells to break up, and it causes inflammation, and then that can trigger the immune system to get active. Now the rash might be purely from the sun, but also it's an indication of a general lupus flare. So sometimes when lupus patients have other organs involved, such as the kidneys, and the kidneys start getting more active, there'll be some more rash as well. So what do you need to do to avoid rash? Well, the main thing is to avoid the sun. So wearing appropriate clothing and hats and using strong sunscreen. Now, when we use various medications to treat lupus, some of them will help rash, such as the Plaquenil or hydroxychloroquine that I'll discuss more later, and the Prednisone as well. Now, the acute rash is seen in almost all lupus patients at some point in time. There are two other types of rashes that are much less common. One is called the subacute cutaneous lupus. And this is a red scaly rash, also in sun-exposed areas. It looks a little like psoriasis. This is called subacute because it's a little slower in its onset and in its recovery. It may come and go over a period of weeks and months instead of a couple of days. This is seen in lupus patients, maybe in 5 or 10%, but it's also seen in the general population. So this can be sort of a standalone condition as well. So you might have a rash like this and never develop any other signs or symptoms of lupus, but from a dermatologist or skin doctor standpoint, it's the same type of rash. It can be treated with cortisone or steroid lotions and with Plaquenil, and of course with sun protection as well. And finally, with rashes, there's a chronic form called discoid lupus. This is a rash that is basically permanent once it develops. It's scarring and inflammation in the skin that goes a bit deeper. If it's often in sun-exposed areas, and if it's in the area of the hair, you'll end up with some loss of hair or alopecia. This also can be seen in lupus patients, maybe about 5%, but it also can be seen as a standalone condition in the general population in patients that never develop lupus. It's very difficult to treat. There's some benefit with Plaquenil or medicines like Plaquenil, and some very strong steroid ointments can be used with a bit of benefit, and of course sun protection. And one other manifestation that is sort of a skin change is what we call Raynauds, and this is the color of the of the skin from circulation in the fingers. So with Raynauds, if a person is exposed to cold, and this may be that it's very cold outside, but even sometimes going inside a grocery store where there's a lot of refrigeration in a cooler environment, they can develop clamping down of the arteries in the fingers, and they'll get this blanching or white, and they can also get purple. This is something that is actually seen in about 5% of the general population, so it's pretty common, but it's seen maybe in 60 or 70% of lupus patients. It generally is not dangerous, but occasionally in severe cases, you can get ulceration of the fingertips, and then we need to treat with much stronger medications. The key to avoiding Raynauds is keeping the body warm, and this includes keeping, not just wearing gloves, but keeping the trunk warm, wearing a nice hat and mittens if it's cold outside. There's also some medications that'll help. There's a medication called nifedipine that we can use for mild to moderate Raynauds, and there's some more potent but sometimes very expensive medicines such as Revatio and some intravenous medicines that we can use if someone has severe involvement with Raynauds. Move on to another manifestation, arthritis, and this is very common in lupus patients, about 90%. But it's usually not a severe destructive arthritis like rheumatoid arthritis, one of our other rheumatic diseases that we see quite commonly. Generally, the mild amount of swelling and stiffness responds very well to medications such as the NSAIDs or the aspirin medicines, Motrin, Naproxen, that sort of stuff, as well as Plaquenil and Prednisone. Now, one thing is the last 10 minutes of the talk, I'll be reviewing in detail these various medications that I'm talking about, such as the Plaquenil and Prednisone. So with arthritis, we often see it in patients at the onset of lupus before they're on any treatment. But when we're in the clinic and our day-to-day clinic life seeing lupus patients, we're not seeing a lot of arthritis because usually it's fairly well controlled with medicines that are on often for other issues. We'll talk a little bit about the lung and the heart. I would divide this into two groups. The first are patients having sort of mild to moderate lung or heart issues. This would be mainly chest pain or pleuritis or inflammation around the heart, which we call pericarditis. So with pleuritis, this is an X-ray with a normal lung on the right side, but on the left side, there's some fluid in the lung. That's why it looks a bit different. There is a lining around the, oops, sorry about that, this is a little jumpy. There's a lining around the outside of the lung called the pleura, and you can get inflammation in that lining if the immune system is attacking the edge of the lining. And this will cause what we call pleuritis. And with pleuritis, you'd have some pain when you took a deep breath, and you might develop some shortness of breath. Generally, this is well controlled with prednisone, although we might have to use high doses initially. So generally, the pleuritis is not a long-term problem for lupus patients, but it's something that occasionally occurs during a flare. Similarly, pericarditis, there's a sac around the heart called the pericardium. And the pericardium has a little bit of lubrication around it so the heart can beat nice and easily. If there's inflammation in that area, it can fill up with fluid and compress the heart, which can be quite dangerous. So if we suspect pericarditis because of chest pain, we can do EKGs, we can do ultrasounds and various things to see if there's fluid around the heart. This usually responds well to prednisone, but sometimes it may require a surgical drainage in order to allow the heart to function normally. Now, as far as severe lung and heart problems, there's a couple of things that happen, and luckily they're fairly rare in lupus patients. They sometimes can develop blood clots that go from the legs to the lungs, and we call this antiphospholipid syndrome, and I'll talk about that a little bit later. This can be quite dangerous and does require treatment with strong anticoagulant medications for a long period of time. Rarely there can be some bleeding in the lungs, which we call pulmonary hemorrhage, where someone is coughing up blood, and this can be a serious emergency requiring a very aggressive medical treatment, including something called plasmapheresis, where we actually do dialysis. We draw blood and circulate it through a machine to clean the blood in order to help stop this from occurring. And then also rarely in lupus patients, they can develop high blood pressure within the lung circulation, the part of the circulation where the heart is pumping blood through the lungs to get the oxygen. And sometimes the blood pressure in that part of the body is too high. We call it pulmonary hypertension. And this also requires chronic treatment. So now we'll move on to really one of the most common issues in lupus, and that's kidney problems. For some reason, the kidney is a very frequent target with lupus. About half of lupus patients develop some kidney involvement, and in about 20%, it's quite severe, and maybe about 5% end up needing dialysis because they lose their kidney function. So when we're in rheumatology clinic, this is one of our real goals, is to try and track patients to see that they aren't developing lupus problems in the kidneys, and if they do, to treat it as quickly as we can. What are the signs of having kidney problems? Well, unfortunately, for the type of kidney problem you get with lupus, there are no early symptoms. So you don't have any pain like you would with maybe a bladder infection or a kidney stone. So a patient has no idea whether they have kidney issues or not. It's something that we have to measure in clinic. One early sign of kidney problems is a high blood pressure, and it's important to treat high blood pressure in lupus or in anyone in order to help prevent any kidney problems. Primarily what we're looking for when a patient comes to clinic is we'll do a urine sample and look for protein in the urine. Protein is in the blood, and it serves a wide variety of functions in our blood, helping to nourish our body. Protein is a fairly big molecule, much bigger than the little waste products we're trying to get rid of in the kidneys. So as the protein in the blood moves through the kidneys for the kidneys to get filtered, the protein should all stay within the blood. But if there's some damage to the kidneys, some holes, if you will, in the filter of the kidneys, the protein will leak out into the urine. So when we check a urine test, we're looking to see, is there protein in the urine? And if there's a lot of protein, that's a real clear indication that something's going on with the kidneys. In addition, when patients come in for their lupus checks, we'll do a blood test and we'll check something called creatinine in the blood. And the creatinine is a substance that is made in the muscles. It has nothing to do with the kidneys per se, but we all make it at a regular rate, and it's excreted in the kidneys in a regular rate. So we would expect the level of the creatinine in the blood to stay stable at about 1. If that creatinine starts going up to 1.5, 2, 2.5, that's an indication that the kidneys are not processing any waste products correctly. So our basic monitoring of the kidney function in lupus is looking for protein in the urine and looking for an increased creatinine in the blood. There are a variety of other blood tests we can do that are specific for lupus patients. There's one called anti-DNA, there's some called complement, and these are specific serologies or blood tests that we've developed over the years that help us to determine if there's some more lupus activity in regards to the kidneys, and we will do these periodically during our regular visits. If someone looks like they're developing a lot of problems with the kidneys, at some point we may need to do a kidney biopsy where we stick a small needle through the skin into the kidney in order to get a little tissue from the kidney, both to confirm the diagnosis and determine how severe it is. How do we treat kidney problems in general? Well, the first thing we want to do, we always want to do good blood pressure control. And this is using usual blood pressure medicines that anyone else would use that has hypertension. If someone comes in with more protein in the urine or the creatinine starting to go up, often the first treatment is using prednisone at high doses. And then later we will perhaps add a long-term treatment with a medicine called mycophenolate or Cellcept or azathioprine or Imuran. I'll talk more about these in a few minutes. And if the kidney involvement looks like it's really severe and someone might be losing their kidneys, then we might use our strongest medicine, which is intravenous Cytoxan, or a somewhat newer medicine called Benlysta. Unfortunately, in about 5% of patients that have severe kidney disease, the medications that we use aren't successful, and people may lose their kidney function, and they may need to go on dialysis. And there's basically two versions of dialysis: hemodialysis, where a patient needs to go into the medical office three times a week for a couple of hours, and the blood is cleansed in a big machine with access through IV lines and arterial grafts. and one called peritoneal dialysis. And peritoneal dialysis is not quite as effective, but it can be done at home where there's a catheter into the abdominal area and dialysis solution is put into the abdominal area, and basically the bowels will help to exchange with the fluid some of the waste products that normally the kidney would do. And this is not as effective as hemodialysis, but it's sometimes much more convenient because you don't have to go into the doctor's office all the time. And finally, if someone is on dialysis, we usually will see if they're a candidate for a kidney transplant at some time. And a kidney transplant is where you take a kidney from another person and transplant it into the patient and hook it up. The kidney transplants in our area are done in the major medical centers, Stanford, UCSF, and Davis. And they're actually quite successful in lupus patients, a similar success in kidney transplant in lupus as with patients that don't have lupus. So now I'll move on briefly to a few other manifestations of lupus. One is problems with the blood count. In the blood, as I showed on that slide at the beginning of the talk, there's red cells, there's white cells, and there's platelets. The red cells can be damaged in lupus, and this can cause an anemia. Anemia is a low red cell count. Generally, when people have anemia, it's from iron deficiency. From somewhere. Generally, it's from iron deficiency, but it can be from the immune system attacking the red cells directly. And if your immune cells decides they don't like your red cells, they want to attack them, it can cause what we term a hemolytic anemia, or a destruction of the red cells. This can start abruptly and may not have many symptoms. So sometimes a patient just doesn't feel very well, comes to the doctor's office, we find out that the red count is quite low. And that's what happened in the first patient.
For bundling made easy, go to Geico.com. That delicious scramble is microwaved? Yeah.
It needs to be muted. They're coming on my screen.
Right, brothers. More like, yeah, right, brother. Get out of here.
The treatment for lupus,
just press an A,
causing hemolytic anemia, is high-dose prednisone, other medications. Sometimes we need to even use something called intravenous immunoglobulin infusions, or IVIG.
For 7 days, and on countertops to keep killing bacteria for 24 hours. Try Microban 24.
The blood count problems can also include what we call thrombocytopenia, and this is where the little platelets, I showed you that in that first slide, the little platelets are little clumps of cells that help with blood clotting. Sometimes those can be the target of the immune system, and if you have a low platelet count, you can be susceptible to bleeding. And this is called thrombocytopenia. This, like having a low red cell count, could start quickly, and patients really don't have any symptoms until they notice some bruising. The treatment is similar, high-dose prednisone, and sometimes special intravenous medications. Now, another area to discuss in lupus is neurologic problems, and the first four that I have mentioned here are problems that really can be seen in anybody, not specific to lupus, and the treatment is similar. So lupus patients can have headaches, and the treatment is similar to anyone else with headaches, which find satisfactory treatment. Lupus patients can complain of memory problems. We don't really have any specific treatment for that. Depression, which we use the standard antidepressive medications, and rarely lupus patients will have convulsions or seizures, and once again, the treatment is usual. There are some things that happen that are much more specific to lupus and much more serious. They can have numbness in the hands or feet, and sometimes this can be due to what we call peripheral neuropathy, or some damage that's occurring in the small nerves that go out to the hands and feet. There's also a process called transverse myelitis, where the immune system attacks the spinal cord, and that can be a real emergency, but luckily it's quite rare. I've seen it maybe twice in my 30-year career. There's a variety of treatments we use for those. You can also have muscle weakness or myositis, where we can tell by blood testing and by biopsying the muscle there's inflammation in the muscle, and this can be treated with prednisone and other medications. And finally, people can have strokes or clotting problems related to antiphospholipid syndrome. I've mentioned the antiphospholipid syndrome a few times, and that's the last of the clinical symptoms that I'm going to talk about. It's a tricky name, antiphospholipid syndrome. This refers to antibodies that are attacking some proteins of blood called phospholipids, and that's where the name comes from. When I started my career at Valley Medical Center in the 1980s, we really weren't aware of this syndrome as a cause for blood clots and miscarriages. This really came to light in the late 80s, 1990s, as scientists noticed some particular blood tests that are related to clotting problems. So these blood tests, I list them here, not that you'll remember them, but maybe your doctor has talked to you about them. There's a couple of tests that are related to blood clots. There's one called an anticardiolipin antibody. There's one called a beta-2 glycoprotein antibody. Another called the lupus anticoagulant, or there's an RVVV is the nomenclature for it. If a patient has one of these or several of these antibodies in their blood that we can tell by a blood test, then they're at increased risk of having blood clots. This is true of patients with lupus, but also patients in the normal population. So the blood clots can be venous. In the veins, you can get clots in the veins in the legs or in the lung, the pulmonary embolus that I talked about earlier. Or you can get arterial clots like a stroke or a heart attack, and these can be quite serious. Luckily, they're uncommon. It's interesting, these same antibodies that can cause blood clots can actually increase the risk of women having miscarriages when they're pregnant. And as I mentioned, this occurs in lupus patients, maybe 5 or 10%, but also in the general population. So if we have anyone who's having multiple miscarriages, or maybe a 30-year-old that has a stroke, doctors will check for these antibodies because sometimes this is the cause of unexpected clots or miscarriages. So what do we do about this in lupus patients? Well, the first aspect is prevention. So if we check these lab tests and find that a lupus patient has antiphospholipid antibodies in the blood, but they've never had any clots, do we have anything to prevent them from having clots in the future? And the answer is basically no. There have been studies looking at maybe adding a low-dose aspirin to their medication regimen to help prevent clots in the future. And sometimes the studies are mixed. They show a little bit of benefit, and maybe Plaquenil helps. The more significant question would be if a patient already has blood clots and is noted to have these antibodies in this antiphospholipid syndrome, then we are very worried they're going to have a lot more clots in the future. So we will treat chronically, maybe for the rest of their lives, with a strong anticoagulant called Coumadin or warfarin. You may be aware that there are newer anticoagulants that are easier to use than Coumadin that have been used in the general population for people with blood clots. These are called DOACs, and these new drugs have been out about 5 years now. But so far, studies have not shown that they work well in lupus patients with this condition, so we're not recommending them as initial treatment. And finally, in regards to miscarriages, we're mainly concerned if a woman has had prior miscarriages, particularly in the second or third trimester. And so if any woman, lupus patient or in the general population, has had second or third trimester miscarriages, they'll generally be checked for these antiphospholipid antibodies. And if they have them, then they will be put on a combination of aspirin and injections someone gives themselves once or twice a day of heparin in order to help maintain the pregnancy. So I hope that wasn't too overwhelming. I really went over a lot of different things that can happen to lupus patients, but I want to really emphasize that what I mentioned in the very beginning is in a particular lupus patient, they might see one or two of these various manifestations. And generally, if you're a few years into your lupus and you're sort of tracking with kidney problems and something else, that's going to be the main issue you're dealing with for the upcoming years, rather than all these other things happening. But I wanted to mention them all in order to give you an understanding of symptoms, and maybe of the audience, maybe many of you have had some of these. So now we'll get to the final part of the talk. I'll briefly mention how do we diagnose lupus, and then I'll go over quickly some of the medications. diagnosis is a real key part of diagnosing lupus when we suspect someone may have it is a blood test called an anti-nuclear antibody, or ANA. This is a test which was discovered in the 1950s and has been really the base rock of our treatment diagnosis of lupus, is having this anti-nuclear antibody. It's seen basically in all lupus patients. But to make matters a little confusing, it's seen in about 5% of healthy people. So when we're doing a rheumatology practice, we do see a fair number of people that have a variety of symptoms and have had a positive anti-nuclear antibody. And that's what our job is to do, is to sort out, is this really a lupus patient, or some of the healthy people that tend to have this antibody. There are a variety of other serologies, we call them, special tests for lupus patients that we can use to help diagnose lupus and predict lupus activity. So in general, what happens is we need to see a positive anti-nuclear antibody to diagnose lupus in combination with several other organ problems. And we've just been talking about them, the rashes, arthritis, kidney, blood, or nervous system problems. Prior to a year or two ago, the standard for diagnosing lupus was a positive ANA and at least 3 organ systems. New to the field of rheumatology and just a year ago is the European and American Rheumatology Associations have adopted a new scoring system for lupus, where they assign points you get a point like 5 points for kidney problems and 2 points for a headache and so forth. There's a point system for all the various things that can happen, and they use that point system to add up to decide if someone has lupus or not. So how do we treat lupus patients? Well, there's some general things that we like to do for everybody that once we diagnose them with lupus, and that of course is, as we mentioned, is sun protection, blood pressure control, no smoking, and try and reduce stress as much as we can. We like to have a brief discussion on pregnancy, depending on the age and gender of the patient, pregnancy issues. And with medications, probably everybody should have a vitamin D level checked and be on vitamin D if it's low. People should be on calcium to help prevent osteoporosis. And I think most rheumatologists now would advise that all lupus patients be started on Plaquenil or hydroxychloroquine, because there's evidence that helps to keep the disease calm and prevent serious manifestations of the disease later. In pregnancy counseling, just to go over this very quickly, in general, it's okay for a lupus patient to get pregnant if the lupus is not active and is not flaring. Now, that's not always an easy thing to determine, but that's the general rule of thumb. And we also need to make sure that if someone's considering pregnancy, that they're on medicines that don't cause trouble. And the Plaquenil, Prednisone, and azathioprine seem to be okay with pregnancy. The other medicines you'd need to discuss with your doctor. It's important to keep in mind that fertility is not decreased in lupus patients. A woman with lupus is just as likely to get pregnant as anybody else. So it's important to consider family planning. Another question that comes up, if a lupus patient thinks, well, if there's some genetic tendency to the disease, if I have children, are they going to get lupus? And the answer is that probably if a woman has lupus, probably about 1 in 40 of her children would be at risk of having lupus. So in general, we don't advise lupus patients not to have children, because if you had 40 children, 1 would have lupus and 39 wouldn't. Another aspect of pregnancy is breastfeeding, and we also need to be careful with the medications during breastfeeding. And there's medicines like the Plaquenil, Prednisone, and azathioprine are considered to be safe. There is a good website that has a lot of information for patients, lupuspregnancy.org. In regards to vitamin D supplementation, vitamin D does have anti-inflammatory properties, and it is involved in how the immune system develops. Lupus patients that are deficient in vitamin D have increased disease activity and a risk of blood clots. We would recommend replacement of vitamin D. Usually it's 50,000 units in a pill once a week if the levels are low, so vitamin D levels should be checked periodically and replaced as needed. And then final, in the 5-10 minutes of the talk, we're going to go over specific comments on the various medicines that we use in lupus. Plaquenil, Prednisone, Cellcept, Imuran, Tacrolimus, Cytoxan, Rituximab, Benlysta. Plaquenil is a very important lupus medication. It was actually used in the 1940s during World War II, and it is related to a medicine called chloroquine, which is an anti-malarial. So it was a medicine first devised to treat malaria. And what happened is in World War II, it was used in the United States troops in World War II. So millions of troops were given chloroquine to help prevent malaria. And what was found is some of those had lupus, and the lupus got better. So we've been using it since then. Up until about 10 years ago, we thought it was just a nice, mild medicine for joint and skin problems, and it calmed the immune system some. But studies have clearly shown that it actually is much more potent than that. It helped prevent lupus flares and improve survival. And there was an important study in Canada in the 1990s where they randomly kept people on Plaquenil or took them off because they didn't think it was that important. But they found when they stopped the Plaquenil, people had major flares. Now, the one problem with using Plaquenil or hydroxychloroquine is there's a rare risk of eye problems. You can get decreased vision from damage to the retina. The risk is fairly low. There's about a 1% risk after about 10 years of use, but after 10 years of use, the risk slightly climbs about 1% per year. Current recommendations that came out about 10 years ago are that when we're starting Plaquenil, we'll have someone see an eye doctor for an eye check in the first couple of months. And then we don't need to really check the eyes for the next 5 years because the risk is very low of any damage. But then after 5 years of use, we check it. We send people to the eye doctor every year to be checked. And we like to keep the dose of the Plaquenil below about 5 milligrams per kilogram, which is a little bit more than about 2 milligrams per pound. So most patients will end up on 300, 400 milligrams of Plaquenil. And I mentioned I just note below, there's a couple of special eye cameras that they're using now to detect this eye disease that we didn't have 10 years ago, but are commonly in use now. And I can't even pronounce their names, but there they are. Prednisone is a key medicine for lupus. This was discovered in the 1950s. We like it because it's very strong and it works very quickly. It works within hours or within a day. So if a lupus patient is very sick and they get started on high-dose prednisone, it's a very quick way to calm down the disease. However, if you've been on prednisone, you're quite aware there's a lot of side effects: weight gain, puffy face, risk of diabetes, osteoporosis, cataracts, heart and circulatory problems when you're on it at a high dose for a long period of time. Ideally, we would keep the dose under about 7 milligrams a day. And one thing, if you've been on prednisone chronically more than 3 to 6 months, you have to be very careful when you lower the dose of prednisone. The reason for this is that we all have cortisone in our bodies. It's a very important hormone in our bodies. We make it in our adrenal glands, and everybody makes about 5 milligrams of prednisone a day. If you're taking pills of prednisone to treat lupus, your body decides it really doesn't need to make it anymore. So after about 3 months of daily prednisone use, we lose some of our ability to make it in the adrenal glands. And it takes the body a while to ramp that up again, the production. So if you're taking prednisone for 3 to 6 months at high dose, you aren't making very much on your own. And if you stop it abruptly, your body has less prednisone than a usual person would have. So the bottom line is it's important to work carefully with your doctor and reduce the dose gradually, particularly when you get into the lower dose ranges. Now, a few other medicines, Imuran or azathioprine, we've had since the 1960s. Moderate strength, like a lot of the other medicines, it has a slow onset. If I started someone on Imuran today, it may take a couple weeks or even a few months before it really works well. So that's why we often use a combination of prednisone for a quick effect and then some of these other medicines to gradually replace the prednisone over time. Like a lot of these medicines, it occasionally can affect the white count and the liver, so we have to do some blood testing to make sure it's safe. What's nice about Imuran is it can be used during pregnancy. A medicine that is to a large degree replaced Imuran for the treatment of kidney disease is Cellcept or mycophenolate. This has been around for about 15 years, also slow onset, but very good for kidney problems, probably better than the azathioprine and safer than another medicine we use called Cytoxan. It also has some problems with the white count and liver, but as opposed to the Imuran, the Cellcept is probably not good to take during pregnancy, so we need to stop it before a woman decides to get pregnant. There's another medicine that not many lupus patients have used called tacrolimus or cyclosporin. These are medicines we used in the 1990s and 2000 to help with kidney issues, and it was moderately effective with the kidneys. The reason I'm mentioning it now is that there is our newest medicine in lupus is Lupkynis or voclosporin. I have never prescribed this because I retired about a year or two ago, and this has just come out in the last year, but it is showing real good responses for kidney problems. So this is probably going to become an important medicine going into the future. There's a couple of intravenous medicines that are occasionally used. One is called rituximab. It's been around for about 15 years. And I mentioned in the very beginning when I showed the different kinds of white cells, there's these B cells, and the rituximab hits these B cells directly, so they don't produce as many antibodies. It's given intravenously, a couple of infusions 2 weeks apart that can be repeated once or twice a year. And this has been very effective in other immune diseases, and we thought it would really work well in lupus, but ends up that it's helps with some of the blood problems and maybe with severe kidney disease, but not as useful as we would have hoped. Cytoxan or cyclophosphamide is really our most potent medicine, first used in the 1960s. And one of the doctors that was key to developing Cytoxan and using it in lupus is our current friend, Tony Fauci, who is very involved in the COVID, and you've seen him discussing COVID in press. His original part of his career was working on lupus patients with Cytoxan many years ago. It's a very strong medicine, works very quickly. It depletes all the bad cells that cause trouble. And it's good for basically all the severe complications of lupus, neurologic and kidney and lung and so forth. It can be given as an intravenous infusion or as a daily pill. So it's a great medication as far as strength, but it does have a lot of side effects. It can really decrease a white count and cause infections. There's a slight risk of bladder cancer and a slight risk of infertility. So it's a medicine which we use sparingly, but only when people are very ill. And finally, the last drug I'll mention is called Benlysta. This is a medication that came out as an intravenous medicine to be given once a month and now can be given as an injection at home. It also hits these B cells directly. I'm not going to discuss some of those fancy words up there. When Benlysta first came out in 2011, it was unclear how useful it was or what indications we should use it for. And so for the first 5 or 6 years, it was really not used too much. But I think in the last couple of years, it's clear that it tends to calm lupus when used over a long period of time. And when combined with other medicines, is very useful to help control kidney disease. So I think this is going to play a bigger role going forward. And I'm not going to discuss these, but just to show you that there's at least 5 medicines out there that are undergoing experimental trials right now that are what we call biologics, which may be very useful for skin problems and other problems in lupus, but they're not yet released. So there are things on the horizon that perhaps in 3 years or 5 years will become real important medicines to treat your lupus. So to wrap up, going back to case number 1, this was the new lupus patient that had rash and fatigue and was seen in urgent care and referred to an arthritis clinic. She has some anemia and a positive ANA blood test. So what I would do for her in clinic is I'd send off some other lab tests for lupus markers. I would send a urine test to make sure she doesn't have kidney involvement. We would do some labs to see if the anemia was due to the lupus, like a hemolytic anemia versus iron deficiency, and we'd check some vitamin D levels. We would discuss sun protection, smoking, and pregnancy issues, replace vitamin D as needed. I would probably offer her Plaquenil as a general medication, and then depending on how bad her anemia is, maybe treat a short course of Prednisone, particularly if she doesn't respond to just being on Plaquenil. And then we would probably start following her regularly every 3 months or so for a long time to keep her safe and answer her questions. And finally, case number 2 was the established lupus patient. This is the patient that has had lupus for a long time, but is now developing some kidney problems. The creatinine is starting to go up, the protein in urine is starting to go up. So what are we going to do for her? Well, the next step would be to check these urine test and blood test again in a few weeks to see if there's really a persistent problem or it was just a one-time blip in the lab tests. If her kidney function is clearly worsening, then we would need to control her hypertension. We would consider referring her to a kidney doctor or nephrologist to assist us in the evaluation and treatment. We would probably increase the prednisone to a higher dose and probably add Cellcept or mycophenolate to her picture. And if she continues to worsen or it's difficult to understand exactly what's going on with the kidneys, we may do a kidney biopsy. And finally, if her kidney function doesn't respond to any of this, we would use IV Cytoxan and maybe Benlysta. So that's the conclusion of my talk. I think I've shared a lot of information with you. I hope it's been useful. And now I think we go into the question and answer segment of the program. Thank you.
Yes, now we will open to our Q&A portion of the event. We will begin with the questions that were asked during the presentation. Feel free to ask any additional questions while we're talking. We will try to get through as many as we can live. And if there's anything that we're not able to get to, we will email you answers to the questions that we're not able to get today. Dr. Bush, how often would you recommend a lupus patient follow up with their doctor for routine monitoring, whether in a flare or whether in just regular maintenance?
Yeah. Well, obviously it's going to depend on the patient and exactly what's going on with them. I think, I'd put people into maybe three categories. One would be a patient that, like that first case I presented, a little rash, a little arthritis, and when we do further blood testing, there's not much going on. We can diagnose lupus, but there's nothing too worrisome. I might see that patient every 3 months for a couple of rounds, and if really nothing else is happening, maybe twice a year. Now, one thing to keep in mind if someone's on Plaquenil, that after that first 5 years, they need annual screening with Plaquenil and annual eye screening. So, we would need to keep track of them to make sure that's happening. So probably twice a year would be the minimum number of visits for a patient with very mild lupus. Now, the second case would be a patient that has a little more going on, like this woman, this case number 2 with kidney disease. And maybe once we get her on prednisone and Cellcept, it all calms down and she's doing really pretty well. I would probably see that patient every 3 months. One of the main reasons is checking some of the labs, because you really can't tell what your red count is. You really can't feel what your kidneys are doing. So we really have to monitor that with lab testing. And if we aren't seeing a patient, it's hard to keep up with lab testing. If we just say get your lab every 3 months, most people, including me, wouldn't do that without a little more face-to-face contact. And then the final would, sort of the third part would be someone who's sick, and then it just depends. And we might see them weekly for a period of time. If they're very ill, we need to monitor the disease, and often we'll have them on some medicines with a lot of potential side effects. So we'd have to watch them more carefully. So I'd say the bottom line is average lupus patient probably every 3 months, 3-4 visits a year. A mild lupus, maybe 2 visits a year. And if someone's during a period of flare or illness, it just depends.
Thank you. And as a reminder to the audience, you can ask questions. There's a button at the bottom of your Zoom labeled Q&A. Just click on that and type in your questions for us. Another question we have is lupus patients have a lot of different symptoms, some of which are serious, some of them aren't. Especially for newer lupus patients, it's difficult to determine what is serious versus what is just part of the disease. What recommendations would you give for a patient as to what they should alert their doctor to immediately versus something they should bring up at just their regular maintenance appointments to their rheumatologist?
Well, it's a hard question to answer, mainly because I spent the bulk of the talk discussing all the different organ systems that can be involved. So when you look at that, it's hard to not have a reaction saying, any symptom I have could be lupus, a common cold, a headache, and so forth. So there's no easy answer to it. A part of it is I mentioned any particular lupus patient, usually 2 or 3 organ systems will be involved, and not all of them. So generally, if they're coming in with rash and kidney problems, we will discuss signs and symptoms related to those specific problems and what we are looking for. I think early on in lupus, I would err on the side, from the patient's side, I'd err on the side of contacting my doctor about many things that worry us, because it takes a little while to sort it out. Also, this is really where the role of the Lupus Foundation comes in, is patient advocacy groups are very useful to help discuss, how serious are various matters, what symptoms people usually have, which symptoms end up resulting in severe consequences versus mild consequences. So it's a very difficult area, and it takes a while. I mean, it takes 6 months to a year, I think, generally when I have a new lupus patient, for the two of us to come to terms on sort of, what do I need to know and not need to know? And it varies a lot from patient to patient. So I can't give you any easy answer to that one.
Yes, definitely one thing that I've noticed over the years with all the patients that I've spoken with is there's never easy answers.
Yeah.
We have another question in. It's regarding nutrition and lupus. There's a lot of information out there that certain foods make lupus worse, certain ones help make it better. Do you have any nutritional recommendations for a lupus patient?
I really don't, as far as foods they might be sort of allergic to that would make lupus worse. The only food out there that we really know makes lupus worse is alfalfa. And most of us don't eat a lot of alfalfa, but there's been experimental trials, I think, of monkeys eating alfalfa that caused lupus failure. So cut down on your alfalfa. I think some people do use alfalfa. Alfalfa's out there, I think, as a food supplement. But other than that, it's really not clear. There are some issues like, vitamin D, keeping your vitamin D levels up, calcium and so forth. It can be done through diet versus through medications per se. But I've been on the lookout for that over my entire career, over research that would be specific to certain certain foods that might flare lupus, but I really didn't find much.
Okay, thank you. What treatments or medications would be most helpful with joint pain and fatigue?
Well, fortunately, if you will, the Plaquenil is very useful for that, hydroxychloroquine. And, I felt very sorry for lupus patients during all the political stuff that happened with the Plaquenil, with the COVID. It made it very difficult, and it made it difficult to access it. And it would have been nice if the Plaquenil had helped COVID. I mean, anything would be nice in that regard. But on the other hand, now I think that once that calmed down, you have your supply of Plaquenil is secure again, because I know for a while that was hard to get. But luckily, Plaquenil is actually a very effective medicine for helping with skin problems and joint problems, some of the milder problems with lupus. And that's how we employed it for the first 30, 40 years of treating lupus in recent times, until we found it was really a sort of an important background medicine to have on board to help prevent lupus flares. Prednisone always works, but it has a lot of side effects. So you might consider Plaquenil with low-dose prednisone. 5 milligrams or so is relatively safe, and it would help with joint problems. But we like to avoid prednisone if possible. Sometimes we can get away with using prednisone for maybe just a few weeks during a flare, but often people quickly get used to it and don't like to stop it once they get started. You could also use the aspirin medicines, Motrin, Naproxen, and so forth, if you don't have kidney problems.
Okay, great. We have a question in about holistic treatments, specifically cannabis. Have you found any cannabis treatments that are effective for fatigue and joint pain associated with lupus? Is there research going on now that it's becoming more legal in more states?
I can't give you I haven't kept track of that, so I don't know specifically. Certainly, I know that the THC ointments and so forth, I have a lot. Those are becoming more popular in the last few years when I'm not in practice any longer, but I know from family and friends that they tend to be fairly effective in anyone for joint complaints, for aching. I have attended the more recent annual lupus meetings and haven't heard much about use of cannabis in lupus as far as specific studies looking at activity of lupus and so forth. I suspect that's being studied somewhere, but I don't have any more information on it.
Okay, thank you. What does Benlysta essentially do, and does it have a high success rate?
Well, Benlysta, I mentioned that as the last medication. What it does is the B cells in our immune system make antibodies, and the antibodies can cause trouble, can cause lupus activity. B cells are usually controlled by the T cells. So the T cells are really the brains of the operation, and they will direct the B cells how much antibody to make and when to make it. The B cells, though, there is an independent pathway through something called a macrophage that isn't a T cell and isn't as smart as a T cell. And the macrophages can also stimulate the B cells as sort of a side issue. And that's what the Benlysta is blocking, is that B cell stimulation that's not coming from T cells. I mean, that's the technical side of it. So what's happening is it's basically slowing down the B cells, making less antibodies. And in doing so, we're hoping that lupus calms down. And when it first came out, the studies were not very helpful to clinicians because they didn't show a great benefit. And so it was a little unclear when it came out 10 years ago what we were going to do with it. And my personal experience is I had maybe 6 or 7 patients I tried it on and didn't get much success. But more recent studies have shown if you combine it with some other treatments like the mycophenolate, it's very useful for kidney disease. There's very good success in a few studies. And there's studies also showing that when you use it for a long period of time, sort of like Plaquenil, when you use it for, 2 years in a row, it helps to keep lupus quieter. So it's helping lupus by decreasing antibody production through this independent pathway that causes trouble. And it looks like it has some benefit. I think we may be still 4 or 5 years away from fully understanding when we should use it in our recipe of treating lupus.
We have a patient saying that their rheumatologist put them on Prograf, and they're asking, what are your thoughts on that medication?
Yeah, the Prograf is the Tacrolimus that I mentioned, or it's used a lot in transplants, kidney transplants. And we've used it, cyclosporin and other medicines. There's that category of medicines that we used a little more in the 1980s and 1990s, but then mycophenolate or Cellcept came out for kidneys and was very successful. So that sort of took most of our attention. I think it's a useful medicine. With that particular medicine, you need to keep an eye on blood pressure and kidney function because it can sometimes cause some problems with the kidneys. But it's not as commonly used as mycophenolate. I think it's a little trickier to use because it takes a little more monitoring of blood pressure and blood, but it's certainly a very strong medicine for lupus, and in some patients it's the best medicine they can use for their kidneys.
We have another question in, how common are long-lasting lung-related complications? I have had inflammation in my lungs, and what it feels like my ribs are over 2. She's had these symptoms over her ribs for about 2 years. Heart issues and pulmonary hypertension have already been ruled out.
Okay. Yeah, it's hard to comment on a specific case without seeing all the information in front of me. But, we have the pleurisy that I mentioned where the lung lining can be inflamed. That's maybe in 10% of lupus patients. And my experience is that maybe 90% of the time it's pretty easily controlled with medications that over a period of a couple of weeks it goes away and doesn't come back. But it is possible you can get chronic pleurisy. So there are a few percent of patients out there where that becomes a lot harder to treat. And that often is a little hard to diagnose because you may or may not see it on CAT scans and so forth. Of course, in that setting, we would want to make sure the person doesn't have pericarditis, inflammation around the heart, and that they don't have pulmonary hypertension. And it sounds like that's already been evaluated in her. So that's getting to be difficult. I would work alongside with a pulmonary doctor in this case to try and sort out what might be going on. But this is a kind of problem where we see patients in consultation, and it takes, spending an hour with the patient and looking at all the records and studying all the films and so forth to try and help determine what's going on. So no simple answers in this kind of setting.
Yes, lupus is a very individualized disease, and patients need to be treated very much on a case-by-case basis. But thank you for helping us get a little more generalization for information purposes. We have another question come in regarding over-the-counter pain medications for lupus. Could you please explain the difference in how naproxen, acetaminophen, and ibuprofen treat pain, and which are typically more effective in treating pain caused by lupus? If you do not have kidney issues, is there a limit to how much should be used of these medications?
Yeah. Well, the ibuprofen and the naproxen are similar. We call them NSAIDs, non-steroidal anti-inflammatory medications, and those have been around for a long time. And there's about 5 or 6 common NSAIDs out there. The naproxen and Motrin, as far as which is more effective, I think the naproxen is probably a little bit stronger than the ibuprofen. But studies have shown it varies from person to person. One person likes one more than another, without any particular pattern. Both of those can cause trouble if you already have kidney issues. They both can cause kidney damage. So you have to be careful in their use if you already have kidney disease. The acetaminophen or Tylenol is not an NSAID and doesn't hurt the kidneys in sort of day-to-day use. So that would be, if a person had already had kidney problems, then the Tylenol or the acetaminophen would be preferable to avoid kidney problems. Having said that, that's where we were in the 1990s, and around 2000 it became clear that if a person uses acetaminophen at high dose, 6-8 pills a day for many months and many years, that can cause some kidney problems. So in a short-term use, using it for a week or two at high dose is not an issue. Low dose, long-term is not an issue, but a lot of acetaminophen for a long time can be a problem. So you talk to your doctor about that. So out of those, if it'd be probably preferable to try the acetaminophen first because it doesn't have any kidney issues with usual use. If that doesn't work, then either ibuprofen or naproxen, depends on the person and the individual.
We have a patient asking a truth or myth question. They had heard that lupus kicks in every 7 years. Is this a myth or is this fact?
Wow. Well, I would put that down as myth. I actually have never heard that. And I must say that it wouldn't make any particular sense to me from a scientific standpoint. And that I did 30 years of practice and always was treating at least 100 lupus patients or so, and I never saw anything like that. People often flared a lot more frequently than every 7 years. And I don't know where that came from. I haven't heard about it, and it wouldn't make any sense to me. So I wouldn't worry about it.
We have a question about the COVID-19 vaccine. Should prednisone or myfortic be reduced before the vaccine, after the vaccine, regarding efficacy? And also, what would be your recommendation about a third booster shot?
Well, I think, first of all, I would, very strongly recommend everybody to get vaccinated against COVID, because the COVID is much more dangerous than the vaccine. And the standard 2 or 1 dose regimen, I would not reduce the prednisone in order to get the vaccine, because if you're on high dose prednisone, you probably need to be on high dose prednisone. So, and high dose I'd say is maybe over 15 milligrams a day. If you're under 15 milligrams a day, my opinion would be that isn't important. Go ahead and get the vaccine. If you're at a high dose, 30, 40 milligrams a day, it may make the vaccine a little less effective, but also you really need that vaccine because you're very susceptible to injury from the virus. So, but also in regards to those questions, I would ask your individual rheumatologist, because there are some recommendations out there from the CDC regarding the use of immunosuppressive medicines and getting the vaccine. And I would say you need to talk to your doctor because the recommendations are quite specific. They would need to look at exactly what medicines you're on, why you're on that dose, what happens if you hold it for a week or two with your health, and you have to balance that out. In general, I'd say just go ahead and get the vaccine. As far as booster doses, I anticipate in the future they will recommend booster doses, but that hasn't been recommended yet by the CDC and by the experts, and I'm in no position to outguess them.
Also, for the audience, just as a information note, we have at the LFNC office hours with Dr. Parsa. I believe they're happening every 2 weeks now. We have a number of videos on our website where he does specifically talk about COVID, the disease, the vaccines, how it affects lupus, and a number of those videos were over time. They started about the beginning of the pandemic, and he covers a variety of topics, but he does address COVID and the vaccines frequently as new information has arisen from the CDC. We have a question in, this patient is a little bit confused about sun exposure. They're not quite understanding how it interacts with the body and to cause issues. Could you please explain the mechanics? Also, is small periods of sun all right if I'm not getting rashes? I just feel very confused about how I can and cannot interact with the sun.
Yeah, what happens with sunlight, anyone that goes out and lays in the sun for 2 hours and they're not tan to begin with is going to get sunburned. And it's clear that the sun damages the skin, and it's the ultraviolet light, I think particularly ultraviolet UVB light, that damages the cells and actually kills cells in the skin. So anyone that lays in the sun for a long period of time is going to get some sun damage. What happens in lupus patients is that when they get just a little bit of sun damage in the skin, that ends up killing some of the cells in the skin that are just below the surface. And that might, if it got worse, cause a blister or something you get with a sunburn. When those cells start dying, the immune system comes in to see what's going on. Why is there some inflammation here? It can tell there's something going on. Immune system comes in, and the release of materials from these cells that are dying can stimulate the immune system in lupus. Lupus patients, if their immune system sees some of the DNA or the content of the nucleus in the circulation, if DNA leaks out of cells, that can cause a vigorous immune reaction in lupus patients specific to lupus. So the reason that we worry so much about sun exposure is that it can cause some destruction of cells, and that destruction of cells under the skin can start triggering the vast immune system and cause the lupus to decide it's going to become active again. So it's very important to protect against getting sunburned, but also, try and avoid most sun exposure, or at least put on sunscreen. And it would be important to use sunscreen even just going shopping and so forth, where you're not really laying out in the sun, but you're going to be in and out of the sun, driving in a car with the sun shining on you. It's very important to try and avoid that initial damage from the UV radiation in the skin that is like the spark that starts the fire. So, and I have had, I've seen it over the years, a few patients that one went to Hawaii and just, couldn't stop from laying out in the sun and had a tremendous flare as a result of that. That took, months and months to calm down. So it's a very important issue.
Do you have a recommendation about what SPF is 15 enough? Is 50 overkill?
I think the higher the better, 40 to 60, might as well use the more potent stuff. I'm not a skin specialist per se, but I know that's what the dermatologists recommend. Is if you're going to apply it, why not apply the one that's stronger and has a better effect at blocking the sun?
Can you please explain the difference between day-to-day living with lupus symptoms versus what constitutes a flare, and also what would be considered a remission?
Well, it all depends. The day-to-day versus the flare. I mean, flares are going to come in a variety of fashions. Some of that's why we want to see patients that have a fairly active lupus every 3 months, because the flare in your kidney disease, you're not going to feel anything. So some of the most severe flares, such as kidney failure or the severe hemolytic anemias and so forth, there are very little symptoms. Our bodies aren't set up to detect that kind of stuff. As cavemen, we didn't need to know what our kidneys were doing. So for some of the severe flares, it really isn't a day-to-day symptom thing. It's really checking labs periodically. I think it's something that my experience working with patients is that they learn what is usual for them. So if they're always having some aching in their hands, and it doesn't really matter if we might see them in clinic, say, let's try and do medicine, let's go up on the prednisone, see if you feel better. And if it seems sort of independent of the disease activity because it doesn't respond to medicines and it doesn't change over time, then that's your usual day-to-day, I would guess. So looking for flares, looking for a different symptom, fever, fatigue, more swelling of the joints, more rash, but also just checking with your doctors regularly so you can check the blood and urine tests. As far as what does remission feel like, I mean, technically remission is no activity of disease, so there should be no rash, no fatigue, and then the lab tests should all look quite stable.
Thank you. That was a great explanation. Thank you. We have a patient asking, why do my fingers always get numb when I hold my phone?
Well, that sounds a little like carpal tunnel syndrome. It may be something non-lupusy. If it's just with holding the phone, I wouldn't be worried about that. I mentioned peripheral neuropathy where the small nerves get damaged, but the numbness never goes away. If you're holding your phone and bending your wrist a certain way, you put more pressure on the wrist, where we call the carpal means wrist. So carpal tunnel is where the median nerve comes through the wrist. And if you bend your wrist backwards or forwards and hold it there for a while, there's a test in medicine called a Phelan's test. So if I push someone's wrist back and hold it for 60 seconds and they have some carpal tunnel, their hand will start getting numb from the excess pinching of the nerve in that position. So I would check with your doctors about the possibility of carpal tunnel syndrome. It's common, not a lupus thing, but it's common in the population.
That brings up an interesting point. Lupus has a wide variety of different symptoms. How does a patient determine what symptoms or new symptoms do they bring up to their rheumatologist versus what would not be lupus related and need to see another specialist or should bring it up with their primary care physician?
I think the answer to that is over time, I'd bring them, I would say that to my own patients coming in. I can say it now because I'm not working anymore, but, bring a list and we'll go over it. And over time, we can sort out which things are lupus related and which aren't. It's also hard, it's hard for the patients coming in saying, what should I mention and what should I not mention? But it's also hard from the rheumatologist standpoint because you don't want to, there's so many things that could possibly happen. You don't want to interrogate a patient about every organ system in the body, every visit, make them a little worried, excess worried. So there's a balance there. But that's a big question. And that's also, as I mentioned before, that's where the patient advocacy groups and so forth are helpful for patients to discuss their symptoms and share what they're feeling and what they've learned from their interactions with their providers.
Great. That seems to be the questions that we have at this time. I'll do a last call for anyone that wants to add in a question. I'll give it just another few seconds to see if anyone else has anything in the audience. It looks like we've been able to cover all of the questions today.
Okay.
Thank you, Dr. Bush. That was very interesting and informative. And to the patients in our audience, don't forget to complete the survey before you leave. This is the end of session 1. We hope you will join us again at 2 o'clock for our makeup demonstration for lupus patients. The link you used for this morning's session works for all of the sessions this weekend. Thank you.
Okay, thank you. Bye.